I am Dr. Philip McMillan, and I'm here to take on an important topic that I think is relevant at this time. As COVID boosters have come out, there has been a strong push to the long COVID community, or people who are concerned about long COVID, that they should be vaccinated to reduce the risk of long COVID. Um, I'll say that there are some people who would argue that vaccines are all bad and therefore they must be stopped. And there's another cohort that says vaccines are all good and therefore they can be used indiscriminately. I am more nuanced, and I think it's important at this stage of the pandemic not to make the mistakes that we've made early on by giving an educated discussion, analyzing what's happening, and most importantly, reflecting on what you know and what you don't know. That's essentially what I'm talking about here. So, before I start, I'd just like to take the opportunity to remind anyone who is interested in the Macmillan research courses. We have free and paid courses here that you can take the look at the link and see what you're interested in. Any kind of support would be appreciated, focusing on all kinds of issues that could be relevant in relation to the pandemic. So let's get back to the question. And this really was a question that was asked of me by someone who has long COVID. And they asked me, what should they do with regards to the booster? Now, I have to be careful with how I answer because my role is not to give you direction, but explain what the science is likely to indicate. And so this is essentially all that I'm doing. And it's coming from a paper that was published just recently. The link is in the description, and here it is. So, in this paper here, it was published on the 15th of September 2023, and it's about vaccination after developing long COVID, impact on clinical presentation, viral persistence, and immune responses. And this paper is likely to have been part of the reason why the new head of the CDC was emphasizing the fact that vaccination protects against long COVID. And I think that we just need to be careful with what we say and clarify exactly what we mean. And so, in this particular paper, and it's important to note that this study, when they looked at the results, they found that COVID 19 vaccination was associated with decreases in the number of what they call post COVID conditions or long COVID. And they found a significant decrease as well with decreased levels of several pro inflammatory plasma cytokines after COVID vaccination. Um, and importantly, they found that the SARS-CoV-2 S1 antigen persisted in the blood of the post-COVID condition participants, mostly in non-classical monocytes, regardless of their vaccination status. That's a very important statement in this because what they're effectively saying is that they found that the patients who were vaccinated had improved symptoms after vaccination. So let's be clear, this was studied in late 2021 into late 2020 into 2021. And let's get exactly who the study population was. And so this is important so that you understand what they were looking at. So they were looking at 83 participants previously infected with SARS-CoV-2, and they had been diagnosed with post-COVID conditions or long COVID, PCC, and essentially, they were based in Canada, Quebec residents, aged from 18 to 100 years. They had a positive COVID 19 PCR test or serology, and they were confirmed as having COVID 19 at the time of symptom onset. So they were referred to their healthcare provider between February 12th and September 8th, 2021. So this is just around the time when vaccines are being rolled out. And so they were enrolled into that, and they used a number of different vaccines across the Quebec region as of January 21, which included the Pfizer, Moderna, and the AstraZeneca vaccine. And they could opt to receive only one dose or receive two doses up to an interval of 12 weeks between the doses. So this was the baseline of the study. And so it's important to note this was early in the pandemic. So this is not talking about a study looking at people who've had 3 or 4 booster doses. They're looking at people who were not vaccinated, who then got vaccinated with long COVID symptoms and had improved COVID symptoms. And that's essentially what they're talking about. So when we nuance it, when we say that there is benefit, it's important to be very clear as to what exactly you mean, because the benefits that you may have seen with regards to vaccination at that time may not necessarily equate to benefits with regards to boosters. And you just have to be clear about it. You may presume it could, but you don't say that it absolutely does. So, with regards to the paper, there are a few points that I'm just highlighting, and I'm not going into it in any huge detail, but here is one of the things that I thought was very relevant. When they looked at the group, and you have the pre vaccination in black, post vaccination dose one in red here, and again, pre vaccination in black, post vaccination dose two, what they were noticing here is that the concentration of spike protein, so in effect, they're acknowledging that spike protein does circulate, especially also the nucleocapsid protein. So you have to remember that these people were infected with SARS-CoV-2, so the nucleocapsid protein is part of the picture. And there was no change in this pre and post dose vaccination, even though they found that the symptoms improved. That's the bit that I think we have to be clear about. My question is very simple. If you find that administering a medication or a vaccine has an effect that you did not anticipate, do not necessarily assume that that is good. There needs to be more research into understanding what exactly is the mechanism where you get improvement. That's really the question, because if you don't know the mechanism for improvement, how do you know what the longer term implications of your action are? This is a really important principle with regards to giving people advice. Usually, we talk about risk and benefit. If you only talk about benefit and never include risk, that is not actually a very good informed conversation for a patient. If you don't know the risks, it's very important to say you don't know the risks. Don't pretend that there are no risks, because some risks only appear in the medium to long term. That's the lesson we've been learning from the pandemic. It's not wise for anyone to say, listen, we have done preliminary research, we haven't seen any major problems, therefore there are no problems. That's not good science. And it is incumbent upon all of the clinical and scientific community to ask these questions. So this shouldn't be an unusual question that I am asking at this point. So coming back to the question as to why would this occur? There are two papers that I think are important. And the first one is to do with class switch towards spike specific IgG4 antibodies after SARS CoV 2 mRNA vaccination depends on prior infection history. I've covered this paper before, and essentially what it's talking about is the fact that after vaccination with the mRNA vaccines, you have higher levels of IgG4. Again, let's break it down simply. IgG antibodies are the long-lived antibodies. That's usually what gives you protection against viral and bacterial infections. Now, IgG is divided into 4 different classes: 1, 2, 3, and 4. 1 and 3 are the main ones, where 1 is both inflammatory, it causes your immune system to respond, as well as does 3. 2 is not usually involved too much. We don't know a lot about what its role is playing, but we do know that IgG4 is what we call a tolerant antibody, meaning that instead of triggering the immune system, it tells the immune system not to target this antigen. Again, kind of like what we see with beekeepers, and the fact that they would therefore have lots of bee stings with bee venom. IgG4 would be high, and the body would be saying, don't worry about the venom because this is just something we have to deal with. So IgG4 rises, especially in the context of um, the mRNA vaccines. Again, this is something that has been largely overlooked by the scientific community. And I'll show you another paper here. And this one was published in December 2022. Again, a similar paper, class switched towards non inflammatory spike specific IgG4 antibodies after repeated SARS CoV 2 mRNA vaccination. So, this is the bit that could lead to improved symptoms when somebody has been vaccinated or even boosted. But here is how I would advise people to think carefully about it. Very important for you to be educated in your decision. So I don't say somebody should or shouldn't get it. What I say is understand what could be a factor in why it has improvement, and then ask yourself whether or not you're willing to weigh in the fact that you don't know that there may be or may not be longer term risks. As long as you've answered that question, that's fine. So here is what it looks like. And I've shared this with regards to my long COVID Substack. So I have a Substack just on long COVID for those who are interested. And you can see in this picture from the paper, you have IgG1 here, IgG2, IgG3, IgG4. Okay, these are the four areas that you've got. Now, in terms of time frames, this one here, I'll probably better use, I'm going to use a slightly better pointer so that it's a bit clearer. This point here is before. This point here is post first dose. This one is after the second dose. This is the follow up of the second dose, and this is the third dose, and then the follow up of the third dose. And this is at IgG1. So, this is what happens after 3 booster doses. You have a peak after the second dose, it falls, then it rises again after the third dose, and then it starts to come down again. The one that is concerning is right here, which is IgG4. And you can see here that before it's very barely detectable. After the first dose, it's barely detectable. After the second dose here, it's barely detectable. But follow up the second dose, you see it starting to rise. And then it peaks after the post third dose and also stays up following the third follow up. This is the IgG4. This is the tolerant antibody. So, my question is very simple. Is the IgG4 the primary mechanism for improved symptoms with long COVID? So, if somebody had long COVID, they get vaccinated, they say, listen, after vaccination, my symptoms have improved. That's wonderful. But what's the mechanism? Is it to do with IgG4? The first question then becomes, well, if IgG4 is doing a reduction in symptoms, does it come with any other risks? My concern would be IgG4 may reduce the ability of the immune system to fight against the virus. So you may see that even though you have less symptoms, you have an increased propensity to be infected by the virus. That makes logical sense. Now, if that's not a problem, that's fine. Next question would be the IgG4 levels being elevated. Does that mean that in the medium to long term, you've resolved the long COVID, or is it going to come back when the IgG4 levels fall months down the line? So, meaning that you're having a temporary reduction in benefit or temporary benefit because of vaccination. Now, again, someone may choose to say, listen, I don't care. I just want to feel better. And however I feel better, I'll take it. And that's absolutely fine. But you have to understand that you don't know what the medium to longer term risks are. The truth is that I could achieve the same result probably with using steroids. Steroids, because it seems that it's immune mediated, if you gave steroids, medium or higher dose, you could probably suppress the symptoms. What we don't know is that going to resolve the problem, or is the person going to be at risk for complications from steroids, which we know. And that's the difference here. We know what the risks are with regards to steroids. We don't know what the risks are with regards to IgG4. So let no one say that there are no risks. That doesn't make sense. What they're saying is that they don't know what the risks are. Again, we have to be savvy. I am not telling anyone what to do. I am educating you about the science. You then have to reflect on the science, reflect on your own personal views, your own personal propensity to risk, and then make a decision. There may not be longer term problems, and that would be wonderful, but don't do it with the expectation that there aren't. That's all I would be saying. The fact that we don't know the risk doesn't mean there are no risks. That is informed consent, letting somebody know this is what we are suggesting. Here are the benefits. We don't quite know the risks, but this could still be of benefit to you. That's the way that we should be having conversations now. And that's the lesson that I hope we've learned from the pandemic. The standard of science, where it insists that somebody must do something without needing to understand it, doesn't fit in a sophisticated society, doesn't fit with educated people. You educate them and you allow them to make decisions that are best for themselves in a way that they understand what they're doing or why they're doing it. I hope this made sense. And for those who have to make a decision, I hope this was of value to you when you have to make the decision in your own interest. Have a great evening.